Okay, so today's topic is a very simple topic, you can say, but for us it is very important. The topic is how to update the consultant or your seniors or your colleague about a new patient or update regarding an old patient, and how to give cross referral to a consultant. Now, this is very important because you have examined the patient very carefully, you have seen the patient very carefully, you are very vigilant, but until and unless you convey that information in a proper way to the consultant or senior or your colleague, he will not get the idea what is happening with the patient, and that way the management can differ or the proper instruction can't be given at that time. Though we know that those consultants will see the patient and plan properly, but informing on phone or informing on WhatsApp, we can share these days, we can share the investigations on the WhatsApp also or any other technology. So these things do play a role in the management of the patient. So we'll discuss important things, how a new resident should inform about the patient to a consultant or anyone he or she wants to inform. So we'll take three scenarios, and one is when you are updating a new patient to a consultant, secondly when you are updating about the same old patient to the consultant, or when you are updating a cross referral consultant, why are you giving cross referral. So first we'll see how, we'll take 2-3 scenarios in which how a resident will inform in a jagged way, and then we'll see what are the corrections needed, how it should be informed. You all, those who are listening, you also need to, you also imagine about or make a flow about that patient. Try to imagine what is happening with the patient. So suppose we'll take the most common symptom, chest pain patient. So suppose a chest pain patient comes to emergency or ICU, or the resident on the duty examine that patient clinically, do all the take all the vitals and do his or her workup, and then informs. So a new resident can inform that, sir, this is a patient with chest pain has come, and the pain is severe, and the vitals are okay, BP is a bit low, but we have taken support, he is dyspneic, there are cracks in the chest, and we have put an IV, and now what to be done, or we shift the patient to ICU. He has done his part, nothing wrong in what he has said, that the patient with chest pain come, there are crepitations, he has taken the supports, he has managed the patient, he has put an IV, now he is shifting the patient. But a proper history would have been, we don't get the information what has happened with the patient and what are the differentials. So now you should say that age and identification. This 40-year-old male or 25-year-old female or 60-year-old old patient, known previous case, comorbidities, diabetic, hypertensive, or post-angioplasty, or post-LVF patient, CCF patient with 30% ejection fraction, if at all records are available, presented with typical or atypical chest pain. If chest pain is typical of the cardiac, radiating to jaw and left arm, or something presented with typical chest pain with perspiration of how much duration, 2 hours duration, 3 hour duration, or 12-hour duration, or since yesterday, or 3-4 days. That is important because it changes the management, because if it is less, it can be in the window period, if it is 3-4 days, it may not be in the window period. So presented with this pain, and on so vitals, and always tell the GC of the patient, means whether it's critical, stable. So this gives an idea to the person who is listening, that how fast he need to intervene, or how fast he or she needs to come, and what are things needs to be done. So at present seems to be critical. On examination, vitals wise, he is hypotensive, we have taken the supports, and in chest there are bilateral capitation, and ECG we found out there is a ST elevation in entry leads or non-specific changes or instability. So to me it looks like acute cardiac failure secondary to acute coronary syndrome. We have loaded the patient with if certain medications are given, and we have taken an IV, taken the supports, catheterization has been done, we have given 1 shot of diuretics, and we are planning to shift the ICU. Anything else needs to be done. So a rough idea about the patient has gone to the consultant. The patient is critical, the patient is having acute coronary syndrome, and now we need to take the patient on the line of ACS. in same scenario, we can have history that patient is a known case of dilated cardiomyopathy or low ejection fraction. So there is no hurry in going for PAMI or something like that. We need to manage on the line of CCL. So this way you get an idea. Now suppose a neuro patient comes or trauma patient comes in which neurology is impaired. So you can tell a trauma patient has come, sir, he was unconscious, we have ventilated the patient, we are sending the patient for CT scan, we have stabilized the patient and there is no other injury. Nothing wrong in the history given, but again identification, young male road traffic accident 2 hours back or 1 day before he was admitted in some other hospital and now come to it, he was having a GCS of 6 or GCS of 10, means if the GCS of 6 means in that M2, M3, M4, this will give you neurological status of the also in the GCS you need to tell that what are the pupils, that one pupil is dilating, pupils are unequal, we have ventilated the patient, stabilized the vitals, no other injury we are seeing and we are suspecting any intracranial pathology or we are shifting the patient in the CT scan. So this way it gives an idea. Now the crux is you should always give an identification of the patient, age, sex, gender means and previous comorbidities, because this narrows down the differential in acute settings. If it's a diabetic patient presented with acute abdomen, acute pain, vomiting, so it can have decay also, patient can have decay. Then after previous comorbidities, the presenting complaint, chief complaint and present status, GC is critical or not critical, stable, and what are your differentials and what have you done. Now you are asking what else needs to be done. Okay. So that way they get an idea that what is happening. Just close your eyes and think about that. If I am listening this history, how I will imagine the patient in my mind. Now, so XYZ patient has been admitted and the all consultant has seen everything, and now in the morning when you are taking off from your duty, you are informing the patient. So on phone the information needs to be crisp. So in morning hours or in busy hours you say that, sir, this patient was admitted yesterday, now he is fine, everything is okay, and the other neuro patient also, sir, that patient was also stable. Now we don't get any information, the specific information. Now supposing that previous MI patient, you need to inform that, sir, PAMI has been done, the patient is not tachypnic, BiPAP has been removed, the urine output for last 24 hours is this much, it is negative by 1.5 liter and seems to be stable right now, there is no fresh changes in the ECG. So this is crisp information. And in neuro patient, suppose the patient got operated for cranectomy. So sir, you can tell, sir, the patient is on ventilator, hemodynamics fine, the sedation is ongoing and the right pupil has started becoming small and still it is sluggishly reacting to light. So we need to continue sedation today or we do need to get a CT scan. Okay. At times other thing can also happen. The resident on duty is so enthusiastic that he give information, all the information required. He doesn't filter out the information like that. Sir, this is 65-year-old male, known case of diabetic, hypertensive, he has been smoker, he has been a teacher, like this. Obviously you need to inform the occupation. Now he is having chest pain for 4 hours, 4 days, and then after that they went to some one hospital where he was treated for 2 days, then they got discharged, and then again the chest pain happened and the patient today came to us, and then right now I think the patient is critical and heart rate is 130, saturation is 80, we have put the oxygen, and then BP is low, so we have taken noradrenaline on 5 ml per hour. The respiratory rate of the patient is 36, so we put an NIV. Then we did think of putting the Foley, so we have done the Foleys, and then BP was not coming, so we took a noradrenaline infusion. It's on 5 ml per hour right now, and the urine was not coming, so I gave 10 mg of Lasix.
Yes.
And the one son also come with the patient, and they are saying that this pain also occurred 6 months back, and it got settled easily, but right now not settling. So you are understanding, he is giving exactly the history which he has taken, what is happening, but this is very lengthy one. You need to filter out from this what is important at the moment to communicate that this is an acute MI patient who is in failure, who is in shock, and it's in the window period, and we need to intervene either by thrombolysis or either in PAMI. So the same way applies in updating a patient. Suppose for updating that neuro patient, you can update in a way like that: sir, the patient is fine, the heart rate is 65, the BP is fine, the saturation is good, oxygen FiO2 is 50%, and the patient is tolerating feed, and the urine output is good, and ABG is also good, and motion has been passed, but you have not told about the GCS, which is very important. So if you are informing the primary consultant on the phone, you need to be very crisp. What is important? Any significant positive finding or any significant negative finding, like the pupil still has not become small, it is not reacting to light, or the patient's urine is pouring 203 ml per hour. So that is important. What is relevant to that particular patient, on which action needs to be taken? Certain things you monitor, lots of things in the ICU and emergency, but relevant positive findings and relevant negative findings needs to be formed, because on telephone you can't give a lengthy stories until unless the consultant asks, he wants to know more. Your history should be crisp, but it should be enough that it conveys the message what is happening with the patient, and this will not come in a one day. Still we practice it. Our residents practice in telling, handing over, during handing over, or when they communicate with me or they communicate with other, we ask the relevant points. What is this? So if in a DK patient, I will ask for potassium. In DK patient, I will ask for respiratory rate. In DK patient, I will ask for ABG. So these things needs to be updated. Now, so you get an idea what I'm trying to say. I'm trying to say that the history or the information should not be very lengthy. It should not be very short. It should be a balance between what is required at that moment and on which the consultant will act, because you are eyes, ears, everything of the consultant or any senior person who are there. They are totally relying on you. So you need to examine everything, see everything, and filter out the information and then convey, because on phone there is not so much time. Anything else they need, they can share on any WhatsApp or anything which or any hospital software which any hospital is having. Now when you are giving a cross referral to a patient, suppose this neuro patient is a diabetic patient and you want to give cross referral to a endocrinologist. So how will you give? Suppose a junior resident gives, sir, this patient was a 25-year-old trauma patient. He had RTA, and then there was a right intracranial EDH or SDH. Then GCS were down, so he was operated, and then he was taken on ventilator. Now he is being sedated on ventilator, and there was also a spine injury there, and we gave steroid to this patient, and now there is a reference for you. This can be one way. And the other way can be also, sir, so and so patient is admitted in the ICU, and you have to see the patient, one reference is for you. This is also both the way you can give. One is very short, one is very detailed. So if you are giving this reference to endocrinologist, why that endocrinologist needs to see the patient, you need to inform. That, sir, yesterday was a trauma patient, young trauma patient, not previously known diabetic. He undergone the surgery, EDH on ventilator, but right now the sugars are very fluctuating. The HbA1c though is 5.6, but the sugars are fluctuating. It's coming in the 200 250 range, and that's why you need to see this. Okay, fine enough. because sugar management is very important in trauma neuro patient. We need to keep a strict control so that to prevent secondary brain injury. Now, suppose a nephro call or a gastro call given in that MI patient. So the patient is in hematemesis or has low urine output. So in the first phase, we can in the first scenario, hematemesis, that MI patient who got thrombolized, and we are giving for upper GI bleed. So resident can give, sir, so and so patient is there, post MI patient, and you have to see the patient. There is a reference for you. No information given. Other one, sir, this patient was there for, he presented with chest pain for 4-5 days, then treated outside, then came to us, and then we found that this patient is having MI, he was in hypotension, then we stabilized the patient on NIV, then we thrombolized the patient because PAMI could not be done at that moment. So sir, 2 days back he was thrombolized and he was doing fine, and for 2 days he was okay, and but today there is some vomiting which was blood stained, and so you have to see the patient. Important. Given nothing wrong in that, but the person will listen, okay, why, a gastro person will think, why I'm being called, why I'm being called, why I'm being called. After 2-3 minutes you will understand, okay, this is the reason. Now, how you can modify this history? Sir, this is an acute MI patient who presented with in shock and cardiac failure. We thrombolized the patient 2 days back. He was doing fine, he was improving, but today he had an episode of hematemesis. Though vitals wise he is stable and there is no drop in the hemoglobin, but you have to see the patient. Or you can see, tell the urgency, sir, so today morning he had an so in all description, and then today he or she had an episode of hematemesis. Right now he is developing hypotension, the blood gas ABG has fallen to 8.8 from 11. So I think it's an I think he is bleeding from somewhere in the GI tract, need to see. So you know, the consultant gets an idea, oh, I have to cross see this patient earliest. If out of 5 references I will see this patient at the earliest, or in the first patient he can take time and then come as a routine call. So practice this. It will not come in one day. You practice this before giving a call to anyone. Just think for 1 or 2 minutes, what relevant information I need to convey to this consultant, or why I am calling to a cross referral consultant, why they need to see. So this is very, very important, and for me I think this is one of the art which everybody who is working in the hospitals, whether ward, emergency department or ICU, should know and master it. This way the consultant and other team will also develop confidence in you, that you are filtering you are identifying the crucial points in that particular patient and informing that only. So that's in short about how to inform a consultant. If you have any comments, you can ask in the comments, or you can go to forums at icu.in. Just go to icu.in/forums. You can ask and discuss in detail. You can also join our Telegram group, where I can reply you in my voice messages. In forums or in the comments I have to type, so I can't type in detail. But on Telegram group I can reply via voice messages, so I can elaborate further. Thank you.